is very interesting. The title says, Decline of Maternal Mortality in Tanzania, Evidence, Innovation, and Partnership Pathways. So thank you very much all for being here. I know there are several sessions ongoing, but for the fact that you chose to be here is it means a lot. So thank you very much. And I'd like to welcome you all to this session. I hope we'll all have an interactive and productive discussion together, right? Yeah. So we're going to have speakers from diverse fields, but we are all united by one goal, which is saving mothers' lives. We are all united by one goal, which is saving mothers' lives. Can you repeat that, please? Saving mothers' lives. Okay, thank you. I hope you remember that through the discussion. Without further ado, may I take this opportunity to welcome the country representative for United Nations Population Fund, Mr. Mark. Let's put our hands together as he comes on stage. So Mr. Mark is the UNFPA country representative in the United Republic of Tanzania since 2022. Mark previously served as a UNFPA representative in Rwanda from 2017 to 2021. And for the past decade, Mark has served as the United Nations as a distinguished leader and advocate for women and young people's health and development. He has held management positions with UNFPA in the Pacific Sub-Regional Office in Fiji, Ireland, Pakistan, Eritrea, South Africa, Nigeria, and Africa Division of UNFPA headquarters in New York. Mark also worked with UNEP in Kenya and the United Nations Economic and Social Commission for Asia and Pacific in Thailand. Let's put our hands together again for our country representative, Mark. Karibu sana, Mark.
Good morning. Good morning. Good morning, colleagues. Good morning. Thank you, Dr. Pili, for the nice words and introduction. And to our distinguished colleagues from the Ministry of Health, our colleagues from academia, civil society, the private sector, participants here at the Tanzania Health Summit, Bariza Sabui. Good morning. It's an honor to join you here on this last final day of the Tanzania Health Summit 2025. And there's so many interesting sessions that are going on this morning, so we really appreciate the fact that you chose this session to be with us this morning around reducing maternal mortality in Tanzania and the importance of evidence, innovation, and partnership pathways. You'll agree with me that maternal health is more than a health priority. It's a cornerstone of human capital development. And it's a reflection of our commitment to protecting the rights and the dignity of women and girls. Every maternal death is not just a statistic, but it's a profound tragedy for families, for communities, and it has far-reaching social and economic costs for our nation. Ensuring that women survive pregnancy and childbirth safeguards children's well-being, but it also strengthens families and contributes to a more productive and prosperous society. As UNFPA, we're very encouraged by the progress that's being made in Tanzania around maternal health. According to the 2022 Demographic and Health Survey, we had significant reductions across maternal mortality, with the ratio declining to 104 per 100,000 live births. And this achievement is a testament to the tireless work of many, particularly the healthcare providers, but policymakers and communities across the country. And it's proof that when health investments are prioritized, they yield life-saving and transformative results. We know what works. We have evidence of what works. Yet, challenges still remain. Too many women continue to face preventable risks, particularly in rural and underserved areas. Disparities persist, and with inequities to sexual and reproductive health and rights, to services, to information, to shortages of healthcare workers, and limited financing for essential medicines and supplies. These gaps can threaten the progress, can reverse that gains that have already been made, and ultimately undermine the country's ability to unlock even its demographic dividend. So colleagues, today's partnerships can accelerate the reduction of maternal deaths, and how we can harness data and digital tools to ensure that decision makers, health providers, and communities have timely, actionable information that can save lives. How can collaboration across the government, academia, civil society, private sector development partners, how can this strengthen the impact at scale? At UNFPA, the United Nations Reproductive Health and Rights Agency, we believe that maternal health is not only about saving lives today, but it's about building the human capital that can drive Tanzania's development tomorrow. Investing particularly in sexual and reproductive health and rights, which means ensuring access to family planning, skilled birth attendance, emergency obstetric care, and comprehensive sexuality education, aligns directly to the aspirations of Tanzania's Development Vision 2050. Vision 2050 calls for a healthy, educated, and empowered population as the foundation for inclusive growth, resilience, and competitiveness in a rapidly changing world. Maternal health and sexual and reproductive health must therefore remain at the center of the national priorities if Tanzania is to realize those long-term goals of 2050. So we're hoping that by the end of this session this morning, we all leave with a shared understanding of where we stand around maternal health. We've explored and exchanged practical strategies to leverage evidence and innovation, and renewed and strengthened our commitment to partnerships that will save lives. Most importantly, I hope this forum can reinforce our resolve that no woman in Tanzania should die giving life, and that every investment in maternal health is an investment in Tanzania's future prosperity. So thank you very much for joining the session today. We've got a rich forum of panelists to stimulate our conversation, and we look forward to all your contributions during the morning. Thank you very much. Asante sana.
Asante sana, Mark, for the very powerful remarks. My key takeaways from your speech is that we have come so far with the 80% reduction of maternal and mortality death for the past decade. So to sustain these efforts, to sustain these gains, we need to look at the evidence. We also have to utilize innovation, but also strengthen our partnerships, because partnerships is a way to go. But also the Tanzania Development Vision 2050 also highlights where Tanzania aims to be. So we're going to get there if we work together, really. Thank you, Mark, for the powerful remarks, and I welcome you to take your seat. Karibu. Asanteni sana wote kwa kuwepo hapa, and our next session would be a brief introduction of the study that was conducted in leadership of the Ministry of Health together with partners including UNFPA and other maternal health stakeholders. This study documented the reduction of maternal mortality rate in Tanzania for the past decade. So I welcome Dr. Mzee for the presentation to give us the key highlights of what this study talks about, what the documentation put in place, but also to tell us where we stand and where we aim to get in the future. Karibu sana, Dr. Mzee. As you take up the stage, let's give him a round of applause, please. Dr. Mzee is the Assistant Director of Reproductive and Maternal Health Department at the Tanzania Ministry of Health. He is a consultant obstetrician and gynecologist. He has held several efforts to improve maternal health services in Tanzania and beyond. He also previously served as the medical officer in charge at Dodoma Regional Referral Hospital and is a certified national trainer in emergency obstetrics and neonatal care. Also interesting, Dr. Nasoro is an obstetric fistula surgeon and he holds multiple advanced degrees. Karibu sana, Dr. Mzee. Let's give him another round of applause, please. Karibu, Doctor, for the presentation.
Asante sana, moderator. As I've been introduced, but today I'm in this seat in the place of Dr. Makwani, my director. Actually, I was supposed to be here, but due to some, because now he's an acting permanent secretary, he has to go back to Dodoma. So I'll represent him as much as I can. And the first thing that I'm going to do is to present to you this study as it has been introduced. And that was about quantifying the use of routine health service data to inform policy interventions in maternal and child health care. This is an experience from our country. Now, as you can see from the board there, my presentation has several headings, but I'll start with the introduction. That we used to know that the global experts and agencies have always been downplaying the value of routine reproductive, maternal, newborn, child, and adolescent health data. As it is mentioned by the moderator here, the maternal mortality ratio has gone to 104 from 556 per 100,000 live births. That data is coming from DHS 2022. But what we want to challenge is that our local data was also showing a figure almost close to that figure. So what I want to present to you is that we can use our locally, the local data from our health information system to portray the progress of maternal, newborn, and child health indicators in the country. So the argument is that the routine data are usually incomplete and do not account for the community at large. But this article demonstrates the significance of HMIS data for tracking progress and determining the usefulness of RAMCA data for improving healthcare systems, particularly in our low resource setting. The study further evaluated maternal and perinatal death reports through the NPDCR system from 2018 to 2040. The methods used. This was a cross-sectional descriptive study which utilized the Tanzanian HMIS data to track RAMCA indicators and their performance and routine reporting of maternal and perinatal deaths across the country. The data were collected from all public and private health facilities at regional and council levels, and the data quality was assured by reviewing and assessing the facility data, the council data, the regional data, and the national data. The review meetings were conducted to ensure that the quality of data, the quality of the data that was submitted. We used 6 variables, we used the study variables as follows: the 6 United Nations Process Framework indicators, the RAMCA indicators, that is family planning, antenatal care, labor and delivery and immunization indicators, number of maternal and perinatal deaths. This study used simple pictures and simple ratios to describe patterns of health system development, including the availability of EMOC services. We also used the RAMCA scorecard. This RAMCA scorecard was developed when we were tracking, you see, when we were, intensively started to track maternal and child mortality back from the fourth phase government. So we developed this scorecard to track the progress across different regions in Tanzania. So we also used it to see how much we are faring in monitoring the RAMCA data. And also we used the trends of maternal newborn deaths from the facilities, as I've said before. Next slide, please. So these are the results that we have got. On the progress in implementing United Nations EMOC indicators, we have about 6 indicators. The first one is the amount of EMOC services available, and we are faring very good according to the standards. And geographical distribution of EMOC facilities, we are also faring good. As the moderator was saying, that there are a lot of facilities that have been constructed across the country. During this 6th phase government, there are about 500 healthcare facilities, especially the primary healthcare levels, that were either upgraded or newly constructed to provide CMOC services. So that is why we are in the green now. We also check the proportion of all deaths in EMOC facilities, and we're also faring good. If you can recall the DHS 2022 data, more than 80% of deliveries are taking place in the health facilities. The net need for EMOC services, we are in between. But for cesarean section rate, we are doing fine. Currently it's about 11%, and that is between 5 and 15% according to recommendations. We are standing at 11%. But the case fatality rate, we are still, we have challenges in the case fatality rate, and this is evident if you are following the NPDCR virtual meetings. You can see that we are not doing fine in managing the complications which arise because of pregnancy and delivery. So we are still having challenges there. Okay, but if you want to have a quick glance of the process, the progress that we are making since we introduced the scorecard, you can see from 2014, our scorecard had a lot of reds. The vertical line is small, the letters are not visible, but the vertical line is the regions, as I said before. We are tracking the progress across all the regions, and the upper horizontal line in the indicators. So when we started tracking, there are a lot of reds. We are not doing fine. But if you look at the progress from 2014 to 2024, now that card shows a lot of greens. So most of the indicators, in most of the indicators, we are doing fine. But if you look at the table below, table number 3, we tracked maternal and neonatal deaths between 2018 and 2023 with the help of UNFPA, as the moderator said, and you can see very good progress. The number of maternal deaths has been declining from 2018. This is routine data that was taken from the facilities, as I said before. And if you look across from 2018 to 2023, you can see from 2018 we had about 1,744 deaths. But come 2023, we have 1,498 deaths. The same with most of the deaths are occurring, they used to occur at referral hospitals. If you look at the percentage of deaths that were occurring and the referral hospitals, they've remained almost the same. In 2018, about 41% of deaths were occurring at referral hospitals. That means from the regional to national level. Regional referral hospitals to national level. It is expected because most of the complicated cases are referred to these places. So some of them will end, the outcome might be death. For the district hospitals, you can see the reduction of the proportion of maternal deaths. In 2018, we had 34.3% of the deaths, maternal deaths occurring at the district hospitals, but yet in 2023, you can see it is about 23%. Now, where are these deaths now occurring? If you compare the health centers, in 2018, we had about 18% of the deaths occurring at the health centers and dispensaries. But that number is almost matching the district hospital deaths. Now, this is because, as I've said before, most of the women now are delivering at the health facilities and dispensaries because now the access to care in the primary health care levels has increased a lot after the construction of the CMOC centers or establishment of the CMOC centers. So some of the complications occur at these levels, and the challenge, we have a challenge there that maybe there's things like late referrals, not consulting, because now we have a lot of medical officers in these facilities, contrary to the previous years that we had assistant medical officers and clinical officers. We have a lot of medical officers in those places, and in sometimes they may be overconfident in retaining patients. Sometimes the patients may die in these facilities. That is why we still have challenges with case fatality ratio. So there are a lot of deaths nowadays occurring at the health centers and dispensaries, but we are addressing this issue. Coming to community, we are also collecting data from the community areas, because every facility has a community that is serving. And the medical officer in charge of the facility know their population. So most of the things that is happening in the community can be reported to the health facility, and if there's a death that has occurred in the community, the team from the facility will go and investigate on the death. We get a lot of information from the facility, from the communities to the facilities, through the CHMT up to the ministry level. So you can see the ratio of the deaths the deaths that are occurring in the community has remained almost the same. In column in 2022, I think there's a mistake there. It is 7. It's not 17, it's 7%. Newborn deaths, we still have challenges with the newborn deaths. Neonatal deaths have remained high, although the number is decreasing gradually. If you look at 2018, it is about 11,524. In 2023, we have come down to 7,164. And most of these neonatal deaths, stillbirths, the two columns below, the stillbirths account to about 60% of all the neonatal or perinatal deaths. Yeah, so this is the situation that we have, and this data is from the routine health management information system. So in conclusion, can you go to the next slide, please? So in conclusion, we can say that the routine data tracking, processing and utilization has significantly contributed to the growth of health sector in Tanzania and informed on population health needs and the interventions that are required, as you have seen from this data. we can extract what is needed to be improved in the facilities. As I said before, for example, we need to improve on the referral system and to change the attitude of the healthcare providers that if you have a complicated case, please do not return the case at the health facility. You can refer it. One. Second, you can consult someone that you may think that can help you, a senior person. And nowadays we have all means of communication like WhatsApp and phones. We are telling the healthcare providers in the primary healthcare levels that you can consult anybody at any time, from the referral health facility up to the Ministry of Health to cry for help. So that data is what is showing us, and that data visualization through scorecards, as I have shown, can enable rapid assessment of health sector achievements. Furthermore, innovative maternal newborn death reviews have generated strategic insights into governance, leadership, skill gaps, clinical practice, attitudes, and accountability, and it has sparked a national dialogue on professional development. We are conducting virtual MPDCR reviews every day in the week. So through these virtual MPDCR reviews, we have realized that we have these challenges and we are addressing them. So our findings are highlighting the value of investing in routine data to enhance data-driven decision-making and periodical progress tracking. We should not wait for the DHS. The DHS will come in 7 years, but the decisions that have to be made so we can make use of our locally obtained data to make these decisions. So thank you for this opportunity. That is at the end of my first presentation. Asante sana.
Thank you very much, Dr. Mzee, and thank you for the very insightful conclusion that a DHS comes after every 10 to 12 years. Then we can currently utilize the local or the routine data for findings, and we can address the challenges as early as soon as possible. Thank you very much. Let's give him another round of applause. Our next session will be the panel discussion. As I've mentioned earlier, we have speakers from diverse fields, but we are all united by one goal, which is saving mothers and newborn lives. So without further ado, allow me to welcome our panelists on stage. I'll start by welcoming Dr. Mzee. Dr. Mzee, sorry, I have to bring you back. Karibu. Let's give them a hand of applause as they approach the stage. I would like to call Dr. Arias Gregory Kuyamba. Dr. Arias is a senior lecturer at St. Francis University College of Health and Allied Science and TTCIH. He brings about 15 years of experience in obstetrics and gynecology. He is a recognized expert in maternal newborn health, and currently he is a president-elect of Association of Gynecologists and Obstetricians in Tanzania, AGOTA. Also, he has served as a national consultant in RAMCA, with the Ministry of Health, local and international partners, and his contributions have been leading in national guideline development, curriculum reviews, and large-scale health workforce capacity building initiatives. Interesting, I think a very unique strength of Dr. Arias Dr. Arias Kuyamba. He has played a key role in institutionalization and implementation of maternal and perinatal death surveillance and response, MPDSR, and is a member of the National MPDSR Steering Committee and he's also a certified master trainer in MPDSR. Another round of applause for Mr. Eros, please. Then I'd like to call on stage Dr. Beatrice Mwilike. Is Dr. Beatrice here with us? Yes. Dr. Beatrice is a professional midwife and academician, also with over 15 years of experience in maternal, newborn, and adolescent health. He holds a PhD in midwifery from St. Luke's University in Japan, also a master's in midwifery on women health from Makerere University in Uganda. Currently, she is a faculty member at MOHAS, and she has served as HOD, Head of Department for Community Health, for about 6 years. And she mentors over 25 masters and 2 PhD students. Dr. Mwilike is also a president of Tanzania Midwives Association. So we have 2 presidents in our panel here. She champions midwifery education, practice, and regulation, collaborating with the Ministry of Health, key stakeholders around RAMCA areas. Thank you, Dr. Beatrice, for joining us. Then I'd like to welcome Mr. Jumanne Tambalike. Karibu, Mr. Jumanne. Mr. Jumanne is a veteran technology and innovation strategist committed to shaping Africa's entrepreneur and innovation ecosystem. He's an influential thought leader. He's an author of a very interesting book called The Diary of African Manager, African CEO, I think. Yes, he's a heritage investor, futurist, and entrepreneur. He's also dedicated to driving Africa's technology advancement and economic growth. He's the co-founder and chief executive officer of Sahara Ventures, and his efforts are trying to bridge the gap between innovation, technology, and policy. He also has notable achievements, including managing the Bumi Innovation Hub with UNFPA, managing the AMO Accelerator Program, but also he has spearheaded Silicon Da. Do you all know where Silicon Da is? Maybe we have something to chat with Mr. Jumanne later during tea break. But also he is recognized for his contribution in the sector and was named the most influential Tanzanian in science and technology in 2017 and 2019. He also sits in several boards, including the Tanzania Institute of Education, Tanzania Startup Association, and also he advises academic institutions like Nelson Mandela Africa Institute of Science and Technology and SUA University. Thank you, Mr. Jumanne, for joining us. Lastly, I would like to call Ms. Lahma Bajun. Thank you. Ms. Pregnant Women and Newborns. With over 10 years of experience in health systems, she has led strategic partnership across government and development sector. The M-Mama system alone has facilitated about 100,041 emergency referrals, and in transition from donor funding to sustainable public financing through collaboration with the Ministry of Health, PRAG, and other developmental partners. Karibu sana, Mr. Rama. Let's give another round of applause to our panelists. Karibuni sana. I know we have had a presentation from Dr. Mzee, so if you have any question, please reserve it to the end of the panel. We're going to discuss more about the study, and so I believe you'll be having more questions as we keep on the discussion. Dr. Mzee, I'd like to start with you again. So from your presentation, we have seen remarkable achievements for the Tanzanian country as well. Decline of maternal mortality for about 80% in the past decade, whereby those declined from 556 deaths per 1,000 live births in 2015-2016 to currently 104 deaths per 1,000 live births in 2022, according to DHIS. And one of the core factor that contributed to this, according to the study, was a strong political commitment and strategic policy implementation. Now, I think we can all agree that nobody wants to see a reverse in the gains that we have fought so very hard to achieve for the past decade. So could you tell us what the government or what the Ministry of Health is doing to sustain the high-level political engagement and ensure that maternal health remains a top priority even with the evolving national agenda? Karibu.
Asante sana. That is a very nice question. Maternal health and child health, they remain the top agenda in this country. Actually, it's not in the country, still globally, it's the top agenda. We have our SDGs, we haven't come to 2030, so it still remains as a top agenda globally. And nationally, it's also still a top agenda. We have reviewed, we've done we are coming to the end of Health Sector Strategic Plan 5. The Health Sector Strategic Plan 5, the target of reduction of maternal mortality in that strategic plan was to go to 200 per 100,000 live births from the previous figure. But we have surpassed that, but we have not reached to the SDG. SDG requires us in 2030 we should be at 70 per 100,000 live births. And for the newborn births, we are supposed to have at least 12 births per 1,000 live births. If you look at the DHS 2022, the maternal mortality ratios come down, that is good, but we have not got to the levels that are required come 2030. Maybe we are on the way to that. So we should not put our tools down. There's still a lot of work to be done, as well as in reduction of newborn deaths. So we still have high political commitment level, and you are seeing in the campaigns that are going around, if we are going to get the same president, she's still, maternal health and newborn health is her passion. But I think even if someone else is coming to take the higher seat, it is still going to be the same. So it is still higher priority politically, and also the government at the higher government levels. That is one. But according to our data, we've also increased the medicine and medical supplies to the facilities. This also includes RAMCA commodities, life-saving commodities like oxytocin, magnesium sulfate, and medicine that have to do with the survival of the newborns. So now the availability of medicine and medical supplies to all the facilities is above 85%. That is a very great achievement. So we still see that we can save a lot of women and children from obstetric complications and the newborn complications by having adequate supply of medicines that are life-saving and the equipment. We are still strengthening our quality of care for maternal and child health. We have improved the review of the maternal deaths and the newborn deaths by leveraging on the communications and technology. We are doing Zoom. We are through the Zoom. We are doing virtual PDCR now, countrywide. Everyone who is engaging in taking care of the women and children and who can contribute to the reduction of death are engaged, they are involved, they can join the Zoom meeting. I think a lot of members, maybe in this room, there are some members who are attending these sessions. And these are very important sessions to see what had gone wrong and to alleviate the problem of maternal and newborn mortality. Whether there's something that is recurring in some of the facilities or districts or region, we dispatch a team of specialists. And here I should say that we thank the professional association very much for taking, for engaging the government, for helping the government in addressing the issues in the counseling facility levels, whether brought out with TAMA, with SATA. So we send specialists from these organizations to go and see what is happening in the primary health care that is causing the recurrent problem of maternal or newborn death. So we are doing that to improve the quality of care, to reduce maternal and child mortality, and I think we are going to improve on that further. But we're also conducting CMEs every week virtually, countrywide. So everybody who can attend, we address issues about complications of maternal, newborn health, as well as anesthetics complications. So everybody who can attend, we are building this, their knowledge through the virtual CMEs. But we are still advocating for increase in health financing. As you know, the budget, the government budget is not going to the levels that are required by the Abuja Declaration. So we're still advocating that with the other advocates to inform that the government is required to spend about 15% of its budget on health. We are still not there, so we still need to advocate that to make us know, to ensure we are not going back to the 556,000 live births. We have the programs of improving human resource for health. We are thinking of improving the quality of leadership for the medical officer in charges who are in the facilities, because through the NPDCR meetings, we realized that some of the deaths are being contributed by inadequate skills in leadership. You know, most of the medical officer in charges, these are doctors, and in their curriculum, there is no leadership and management. But when they are dispatched to these facilities, they are supposed to be leaders, they're supposed to be human resource, they have to employ, they have to use the money that they're getting appropriately. So sometimes there are misappropriation of the resources in the facilities that indirectly cause mortalities. So we are going to improve on the leadership skills, but also we are going to increase the number. We are increasing, we are doing that now, but we are going to increase the number of newborn care units to reduce the newborn deaths, and we are also, we have already, the number system is functioning very well, but as we said before, we want to improve it in order to improve and strengthen referral system. Thank you very much. Asante sana.
Thank you, Dr. Mzee. Maybe I would give you just a follow-up question on that. You have spoken about availability of essential medicines and life-saving commodities in our facilities, and during your presentation, you stated that more than 500 health facilities have been built or renovated for the past 6 years. So what is the government, or what is the Ministry of Health, especially the Department of Reproductive and Maternal and Newborn, is doing to ensure that we do not just have availability of services, but we have quality services? I mean, do the facilities are they equipped with skilled staff? Because that, I think that is the question now, because the government has done a lot to address also the question of where can I get the services, but we still have the pending question of where can I get the quality services? So maybe just in 1 minute, could you tell us more what the government is doing about that?
Asante sana. That is a cross-cutting question. It involves the Ministry of Finance. We have to set aside a budget for employment and deployment. It involves a pluralg, because most of these facilities are at the primary healthcare level. So we have to engage the plurals. As you know, the minister is making policies and guidelines. So much as it is a cross-cutting question, what I can say is the government is making efforts to increase the number of skilled staff. When we are constructing these facilities, it went along with equipping them. A lot of equipment was procured by the government and distributed to these facilities. The health staff, there was employment. Previously, there are no source for employment except in the Ministry of Health and the Ministry of Education, as far as I can remember. So these are the priority areas where they are allowed to employ and deploy. But on top of that, the facilities have the opportunity to employ staffs on contractual basis. So if a facility has adequate funds, they are allowed to employ staffs according to their needs, contractual staff. So all these measures are to make sure that these facilities have adequate staff to provide, because having adequate staff is only one of the requirements to provide quality care. So in terms of the number, we haven't reached there. The human resource, the shortage for human resource for health, I think is more than 50%. So there's a long way to go, but we are making efforts to make sure that the facilities, if they have the funds, and most of them actually, they can afford to employ contractual staff.
Thank you, Dr. Nze. That's very reassuring also. That would take me to Dr. Beatrice. So, according to the documentation of the success of maternal mortality reduction in Tanzania, we have seen that the government has done efforts to employ about 1,800 midwives recruited in the last decade. So what is the role of TAMA? What is TAMA doing, especially when it comes to, as Dr. Nze was mentioning, to make sure that we have quality services? What is TAMA doing in terms of training, mentorship, and retention of the newly employed midwives, particularly assigned to the rural and hard-to-reach areas?
Okay, thank you so much, and good morning, everyone. So I would first start, we have about 42 branches all over the country where we operate, and we have about 4,000 members in the association. And TAMA, as a member association, we have an international confederation of midwives, and in 2011 they started an initiative of twinning the associations so that they can build capacity to associations. So as Tanzanian Association of Midwives, we are twinned with Canadian Association of Midwives. And since then, we have been working together to ensure that we capacitate midwives across the countries and learn from each other's. In 2013, we were able to develop a training package for equipping midwives with midwife emergency skills for them to be able to provide emergency services. And this could cater even for midwives who are also working in the rural areas. So from there, we had a span of projects in support from different implementing partners. And I would like to take this opportunity to thank UNFPA, CUSO International, Canadian Association of Midwives, and LEDO Global Health, who we have been working hand in hand to ensure that we equip midwives with skills, with knowledge and competencies for them to be able to provide the quality service. So Tanzania Midwives Association has been in the front line to ensure that midwives' voices are heard and midwives are equipped. So I'm going to give an example of few projects which have been able to implement with different partners for us to be able to equip midwives and contribute in the reduction of maternal mortality and newborn death. For example, in 2016-2021, we were able to do more and better midwives in rural Tanzania project, and this was conducted in regions of Mwanza, Shinyanga, Geita, Mara, Kigoma, Tabora, Kagera, and Simiyu. So we tried to cover the regions which we saw that they had still higher numbers of maternal mortalities. And through this project, we were able to increase the number of skilled midwives from 122 to 400 by 2020. And we are still continuing to equip midwives also through other projects such as Midwives Saves Lives, which this project was conducted in Simiyu and Shinyanga region. And we used the training package that we developed on midwifery emergency skills to equip the midwives in these regions. And then later on, we had another project, 50,000 Happy Birthdays, which was funded by several stakeholders, including UNFPA, and TAMA has contributed to 33% reduction of preventable maternal death, 31% of neonatal death, and 18% of fresh stillbirth. This was by 2020. And it has really been achieved through capacity building among nurses and midwives who are working in rural areas. And then again, we have been partnering with the Safer Band of Care project as well, in collaboration with the government to ensure that also contributes significantly in the reduction of maternal mortality. And for those who have attended yesterday's forum of SBDC, they would appreciate the massive reduction of maternal death and newborn death. So currently we are also collaborating with UNFPA again to conduct a project called Thamini Uzazi Salama project, which was started last year. And TAMA as midwives, we are co-implementers actually in ensuring that we equip midwives. And in this project, our role also has been also to capacitate midwives with the trainings, especially in the midwifery emergency skills. But also what we did, we had to digitalize the training. So through this project, we are also able to put 6 modules in the national e-learning platform. And as of September this year, we were able to check the data from the Center of Distance Education, and we found 103 midwives have already accessed the materials and have completed the training modules. So we believe through these different projects that we work with different partners, we contribute greatly in the reducing maternal mortality and newborn death.
Thank you very much, Dr. Beatrice. Do you have midwives in the room? Midwives, could you raise your hand? Oh, thank you. Congratulations for the hard work that you are doing. Midwives are strategic partners in reducing maternal and newborn death, and we thank you for the work that you do. Now that would take me to the ground. We have obstetrician and gynecology, who is also the president-elect of AGOTA, Dr. Arias. Dr. Arias, you have been championing NPDSR. You're also part of the steering committee for the national NPDSR team, but also you are a certified master trainer on NPDSR. And in this study, we have seen that NPDSR has been one of the very effective tools in the reduction of maternal and newborn death. So my question would be, how is TTCIH working in collaboration with the Ministry of Health, other stakeholders, to address identified dysfunctions that are such as incompetence and lack of accountability that were found in these reviews? Because it's one thing to review the death, but what are we doing now to address the dysfunctions that are present in these reviews? Karibu.
Asante sana, habari ya asubuhi. Okay, I have different Kofia, but you allowed me to talk on TCH part. TCH is Tanzanian Training Center for International Health. It's a health training institution located in Ifakano. It is led by the Board of Governors, that is the Ministry of Health, Swiss TPH, and Novartis Foundation. Apart from training, we are implementing a lot of maternal health projects with different partners. So coming to our point, NPDCR is a continuous process as a quality improvement intervention, where it has key areas. I can just part in short. We first have to identify the death that has occurred, and then the committee sits to review the death through different information that are collected around the death, with the purpose of identifying dysfunction of the gaps, medical and non-medical contributing factors that have contributed to the death. After getting the gap, the committee analyze and look for the intervention. So they set the action plan or recommendation to solve the problem that has been identified. And then the committee follow up to make sure that the intervention that have been planned have been implemented with the evidence. But coming to our matter, we have to also to monitor the response and to have the evidence of the performing or implementation of the evidence. So one of the components that have been identified as the gap, which is just the competence and the practice of care providers. So TCH has been involved in various steps on achieving this. One is strengthening, because it's a training institution, is strengthening in service training. It has been doing this with several stakeholders, but with the lead of Ministry of Health. One, to develop curriculum on nurse and midwife as a technical lead, but also some curriculum have been developed under our leadership, like advanced diploma in anesthesia, as well as advanced diploma in nurse and midwife. But apart from that, to improve practice and learning, we have also been a technical lead in developing a guideline for clinical instructors who help in providing services. But apart from that, a clinical skill laboratory method, which impact the best way to train in service. But apart from that, we have done a lot on in service, especially on the part of mentorship coaching on the area of emergency obstetrics and newborn care. We have been developing and adopting the evidence-based approach of mentorship, which are three of them, top to bottom, and then peer-to-peer, and the bottom to up. When I say top to bottom, what we do, we obtain the national mentors from the Ministry of Health. We go with them to the facilities. They mentor other providers. Peer-to-peer, apart from using the national mentors, we identify people who are skilled and experienced as providers. We keep them the training and the mentorship skills. We make them as regional mentors. We make them at the hub, and then they go to bring other people to the facilities. So we adopt the hub or the spoke approach, which has brought a lot of results. Apart from that, we have the where we do clinical attachment. There are those providers that need the skill, that need enough time for exposure. So you can't take someone 2 or 3 days to the facility to give someone the knowledge skills or surgical skills. So what we do, we identify these people, and then we attach them to the higher facility, this is the regional referral hospital or zone hospital, not only on surgical skills, but also on issue of anesthesia. But apart from that, we are also working on continuous professional development. We have been part of the team of developing e-learning models of nursing midwife and with other skills. We are working with the MCT and Ministry of Health, DHRD, to develop the model and to make sure they are digitalized and put in a national e-learning platform.
Thank you, Dr. Arias. I say you have emphasized on the use of technology, but also what the ministry and partners are doing, especially when it comes to distance learning. So I welcome all the participants to explore the distant learning platforms for the Ministry of Health, to go through the modules that Dr. Arias and Dr. Beatrice have been talking about. We have so interesting materials for the midwives and all the healthcare providers when it comes to saving and helping mothers. Now, Mama initiative has been mentioned several times by Dr. Mzee, as I think other panelists. So, Ms. Rahma, could you tell us more about the Mama initiative, but also your initiative is very praised for using the second delay, that is reaching or accessing care for mothers and newborns. Can you tell us more about it? But also, I want you to also give us your opinion or tell us more about the strategies that you use to engage community drivers and ensure that they are reliable and accountable and trustworthy, because I know that Mama is involving the local or community drivers. So what are the strategies that you use to make sure they're reliable? Because we trust them with our pregnant women, we trust them with our newborns. So how are you ensuring that they're trustworthy and are partnering with us? Karibu.
Asante sana. Asante sana, Dr. Pili. Good morning, everyone. Just to say what a mama is and what it does. So mama, as you have heard from different conversations that we have had here for the 3 days, is an emergency referral system that expands the quality of care for pregnant women and newborns. It has 24/7 dispatch center that are located in all our regional referral hospitals. When the dispatchers receive calls, which can also be accessed through a toll-free number, 115, when dispatchers receive a call, they do a remote triage and then dispatch transport to make sure that the mothers are taken to the appropriate care or the babies are taken to the appropriate care. One thing that I really need to insist there, the first call always is public ambulance that are sitting in all our facilities, and some of them in the local authorities. And then when the local public ambulance are not available, that's when the dispatchers are using community drivers that are actually recruited by the government as well and paid by the government. As much as Mama is also focusing on delay too, which is transport to care, it also has massive impact on delay 3, because now the government has access to massive data that comes in, shows where are the referrals come from, what are the conditions, where they have been taken, and finally it also shows the outcome of that referral that has been carried in the entire process. So that's in a nutshell what a mama is and what it does. So how are the drivers engaged? How do we ensure their reliability and their accountability? Just to say, a mama is fully 100% owned by the government of Tanzania at this point. We are the partners just working with the government to support them in making sure that a mama gets to every woman and every baby that needs it. And so one of the key strengths that a mama has, it is a multi-ministerial, multi-departmental managed system within the government. So we have Minister of Health, President Office, local government that are leading the MAMA, but again, we have other supporting ministry like Minister of Information and Technology, we have Minister of Finance, we have IGA, we have President Office itself, so the State House coming in to support MAMA. And so this as well cascade into the regional, local level, to the village level. And so how the drivers are actually recruited, they're identified by the village leaders, they're engaged by the village leaders, and then goes to the council level where they work very closely with the police department to ensure that they are assessed to their cars, they have all the requirements that are needed by the legal authority in the country, and then they also engage now the health expert to train them on the basic basic referral emergency response. Okay. And so how, again, in terms of reliability and accountability, just quickly, is the government has built a prompt automated payment system for the community drivers, so they make sure that they are paid on time, and even there is that transparent across, not only from the local level at the MOE level, the facility level, even to the national level where the MOH sit and PRH sit, to ensure that they're paid on time. The MAMA has been integrated into key government system and structure, so the supportive supervision is part of one of the key things that we assess how the drivers are doing, what is the service offered, is there any challenge there, so that they can cascade back to, how we can work closely with the drivers.
That's very interesting, but also I think Mama is teaching us about when we engage the community, the spirit of community ownership and the results that are coming. So maybe I could give you a follow-up question on that. We have seen that Mama is working, and
what is actually happening with Mama system in Tanzania, and it's probably going to happen with other countries as well. So we from Vodafone side, we have been transparent with the government from the understand what are the recurring costs for the system. We have been fronting giving the government, for instance, on the IT system, the source code. So the government owned the source code from the beginning, and so the government has it. And so the fact that the government has owned it, it has integrated in the key government, as I said, sectors and the system. And so the government really makes sure that the citizen are actually informed on what a mama is, how they can engage it. And as I said, it's not only from the technical side. Sometimes when we have health system, we're only thinking of the doctors, the nurses, the technical team that we have in this room. And mama has gone beyond that to other sectors, like I said, MICT, so the information technology, the transportation. It even goes to the political. That's why we have some local leaders that are engaged in the identifying and recruitment of the local drivers.
Oh, thank you. Thank you very much, Rahma. This will take me to Mr. Jumani. We have heard so much about mama from Rahma. And as our innovation, as technology expert and our partner in that area, what are the key lessons from the development and the scaling of digital health solution within Tanzania public health system? What are the key lessons? What are the challenges that you see when it comes to digital health systems and solutions in integrating them to the Tanzania public health systems?
Yes, thank you. First of all, I'd like to commend the partnership between the government and Vodacom, because it's critical to have those relationships. So from Sahara Ventures side, specifically our accelerator, Sahara Accelerator, we've been working with UNFPA Tanzania for the past 10 years to support health sector innovations, particularly sexual reproductive health sector innovations. And some of the critical lessons that we have learned, I've grouped them in 4 areas. The first one is related to technology and infrastructure. There's a lot of very nice, interesting innovations that always emerge. Mostly are digitally related. I think the most recent one include Afya Intelligence and the impressive work they're doing using AI and data to increase access, but also accountability in the health system. But the biggest challenge is availability of infrastructure, especially critical infrastructure, whether it's servers, crowd systems, devices for last mile access. So the first biggest challenge is technology and infrastructure. The second one is the pace of change of our policies and regulation to accommodate these new innovations and technologies. You all know technology is evolving really fast. A lot of new things are emerging almost every day. There are some policies and regulation that the government has been working on. They've been reviewing the National ICT Policy, and now we have the Personal Data Protection Act. All these are critical aspects of how technologies are going to be deployed, especially in the health sector where every data is very sensitive. So we see regulatory and policy challenges is one of also main obstacles for most of these innovators to deploy their solutions. Startups like Saratani AI, where they have to access critical cervical data from hospitals with existing regulatory infrastructure, how do you accommodate them so that they can be able to continue innovate in an environment where they don't have access to this data? Another critical aspect based on our own lessons also is also around business model and sustainability. While most of these innovations, they are very cool, they are desirable, some of them they are very feasible, but from business perspective and sustainability, they really struggle to be viable, meaning that someone has to pay for these services. And as you know, in most of the African countries, health and education services are considered to be public services, free services, which make it very difficult to come up with business model for them to be able to scale and replicate it. And that's why it's crucial to have this partnership, MOH, Vodacom, UNFPA, coming together to subsidize some of this cost and access. At Sahara right now, we work very close with Vodafone through their Afya Pass insurance to try to make sure women are accessing insurance through innovative approaches. So this partnership kind of promote access, especially to hyperlocal and grassroots communities to access these services. And the last lesson in that area is, of course,
accessibility, the customers themselves, the users of these products. There's always issues around digital literacy and inclusion, especially digital inclusion. If a solution you are delivering to them is somehow using high-end technology or require second or third stage access to digital literacy, then somehow you're keeping them out to be able to access it. So we usually encourage them to use SMS applications, USSD application, and solutions that can be accessed, use feature phones so that they can be able to reach out to as many people as possible. So I'll cluster them as you have lessons around policies and regulations, you have lessons around technology and infrastructure, you have lessons around business model and sustainabilities, and you have lessons around customer access.
Thank you, Mr. Jumani. That would be a very interesting issue. You have spoken also about the emerging technologies, the AI, and I think that is one of the areas that we really have to dive into in improving our services and quality care. We have had a very rich discussion with the panelists, and I think we have 15 minutes for discussion. So I would welcome questions from the audience. Could you please raise your hand? When given a mic, state your name, the organization that you come from, but also pose the question direct to the panelists. That would be better. Please be focused and direct to the panelists. Thank you. Volunteers, can we have the mics? We'll start with Dr. Rutasha here.
Thank you. I'll be very brief. I want to commend presenters, Dr. Mzee and the team. Mine actually is an observation, particularly on maternal mortality, source of data. What we are discussing here mostly is DHS, the demographic health survey, and the routine data, which actually can tell us exactly what is happening in our society. But we have really not utilized other sources of data. And I want to bring to the attention on the census monography. Because as much DHS can tell us about the national data, you cannot have the regional differentials from DHS. You can have that from routine. And what we are seeing now is that from routine as well as the census, we are seeing a paradigm shift of maternal mortality from west to east. For example, we are seeing a decline of maternal mortality, thank you very much, at around 70 in Isimiu. We are discussing about Isimiu, 70 and the Singida. But maternal mortality in other regions, especially around the coasts of Tanzania, is as much as more than 200, twice as much over the DHS. So my call on this is really looking and how do we reprogram. As much we celebrate the 104, but also needed to understand what does 104 mean in terms of quantity, in terms of number. Because that number actually brings us to almost 2,000 women dying. If 104, and the health sector strategic plan 5, estimation of 2 million deliveries, and that year it is around that.
Thank you.
The last one is that maternal death is not just an event. It is expression of gender inequalities in our society.
Thank you, Dr.
It's about the social, economic. And what we are seeing from data is that those who are poor, actually, the maternal mortality is driven by poverty. So when we are looking at that, Dr. Mzee, into policy, in terms of regional differentials, but again looking it as not just a maternal mortality, but again really looking at from social contexts. Asante sana.
Asante, Dr. Rutasha, for highlighting, but also emphasizing on the absolute number when it comes to the ratios of maternal mortality. Can we have the mic to the lady at the third row?
Thank you very much. My name is Ivani Kamala from Lado Global Health. First, I would like to really commend the great work by the government of Tanzania through the Ministry of Health and PRALG for the great work they have done with equipping facilities, constructions, the infrastructure, investing in human resource for health and availability of drugs and medication. Mine is a reflection that I would also like to invite the President-elect of Agota to also share his perspective. He communicated about the challenges seen in MPDSR being the competency and knowledge. And we've seen implementing partners, not only UNFPA, but professional association, really investing in training. But I think from the evidence that we've seen in some of the partners, such as the Safer Best Bundle of Care, I think it's a high time to also invest in tracking the way the providers are utilizing the knowledge and the competencies that have been provided. For instance, a training has been done in January for helping babies breathe. How sure are you that they are using the same competency to be confident to save babies with asphyxia? I think it's a high time to have these kind of dialogues, to also leverage already existing evidence-based solutions and digital platforms to track competencies.
Thank you. One mic here from Mr. Afya Intelligence.
Good afternoon, everyone. So my name is Harrison Mariki. I'm the CEO at Afya Intelligence, a startup that actually was birthed through the AMO Accelerator supported by UNFPA. I think the first 5,000 that we won from the AMO Accelerator really helped us to build our business. And currently, we've managed to deploy a solution working alongside with the Ministry of Health and other implementing partners. Our solution is currently used across the country, supporting the quantification of healthcare products in all health facilities this year. So we are very happy and proud that UNFPA support was able to support us through that. So listening to this conversation, I think having worked in that space for some time now, I see there's a lot of opportunity to also look on how we support the private sector. There's a lot of visibility at least now, looking at the routine data collection on what is happening in the public sector, but very little is known within what is happening in the private sector. So that's an area where I would like to bring that attention to the conversation that is going on, to see how also we can work with the private sector to bring up and make sure that we're keeping this in touch. We support community pharmacies in deploying digital solution for community pharmacies as well. And we see a lot of mothers coming in as well, and children as well. But there's very little that is done in terms of harmonizing and looking at what solutions or digital solutions are used there, and what is the opportunity to leverage those digital solutions to bring that visibility to the discussions that we are having.
Thank you.
Thank you.
Thank you. I'll take 2 more questions.
Thank you. So I had 3 questions, but I have to ask one.
Yes, just one, please.
So my question is on the Ministry of Health. The Ministry of Health has introduced the tracking registers for at-risk mothers at the facility level, but it is still paper-based, whereby at-risk mother is recorded, and then there's need for follow-up. But what we learned from the field perspective, the list is there, but we don't have the actual tracking of those mothers who are at risk, and the follow-ups are not there. For a mama part, maybe I ask about the feedback mechanism for the drivers. The drivers are identified, they are working there, but they don't have a platform where they can share their challenges, the payment issues, and other aspects. Can we have a digital solution that may fasten the process of receiving feedback from the drivers and improving more how we can manage the drivers as well? Thank you.
Thank you. I'll give an opportunity to the youth in the room. I'm representing them here, so karibu.
Okay, asante. My name is Goodson Madea. I'm a medical student from MOAS and working as a project coordinator at Tamida. And my question goes to Mr. Jumanne. And that's, we have many youths in this country. And particularly, I'm talking to medical students in different universities. But most of them, they lack exposure to innovation and all those stuff. And they are, I think, most of the innovations in the health sector, like Saratani AI and Mkanda Salama, comes from medical students. How are we planning to engage them from early years in the universities and even sensitizing them into area of innovations? Maybe we go more to advanced schools. And my other thing is to a mama. I've been in the field once in previous years, and sometimes it happens, you are in Dodoma maybe, and just calling the call center and the phone goes to Mbeya or to the other regions. So how are you going to segregate the calls according to the centers so that it will be going to the nearby center to fasten the process? Thank you.
Thank you. Thank you for the very wonderful questions. Let's get back to our panelists. Dr. Mzee, would you like to start?
Asante, Dr. Pili, and those who have asked very pertinent questions. I think there was one from Dr. Rutasha. He said it was an observation. And there was another one from, I think the speaker did not mention his name, about tracking registers. Now, Dr. Dadi's observation is true. We have 104 maternal deaths for every 500,000 live births. This number represents the country data, but we have discrepancies across, different regions in the country. Not only maternal mortality, but other indicators in RAMCA. For example, Simiyu, if you look at family planning data, Simiyu is performing below the national average. I think it's 9% maybe, compared to Lindi, which is 50%, that is family planning, modern contraceptive prevalence rate. Now, coming to the maternal mortality, it's also the same. The shift is, Dr. Dad is talking, is true, but according to the routine data, the maternal mortality data or newborn mortality data is collected on daily basis, as Dr. Elias was saying here. For example, now if I check in my, my handset, we have a group of the RRCH calls in the country. They are notifying every day using their smartphones. So this is the data that is being collected on the daily basis 24/7. And according to that data, if you take absolute numbers of maternal mortalities, there are about 3 or 4 regions which are leading. The first one is Mwanza. The second is Dar es Salaam. The third region, I think, is Morogoro, and comes Tabora. So if you look at the birth rates of this region, these are the areas where women are giving birth to a lot of children. But if you take it as a ratio, the ratio is higher in the southern region, the Mtwara and Lindi. If you take it in proportion-wise, you'll find out that these other regions have high mortality ratio. But if you take the absolute numbers, then these areas, the highly populated areas, have high death for obvious reasons. The reasons are known. If you have a populated area, there are a lot of births, and you expect also that you may have more deaths. But for Mtwara and Lindi, the southern region, we have other factors in play. You have few deaths, but a lot of deaths if you take the ratios. We know the challenges with the regions. The number of healthcare providers may not be adequate and things like that. So we appreciate, Dr. Daddy, that we have regional discrepancies, but the government is working on that. The ways to alleviate these challenges, we have devised a system of conducting mentorships across all facilities, especially at the council levels in the country, and that is where we have taken on board professional organizations such as Agota, TAMA, SATA. We are sending professionals from these organizations to mentor the healthcare workers in these facilities, in the council levels, because about 80% of the people the healthcare provision is at the primary healthcare level. So we are building the capacities, the competencies of healthcare workers in these areas in order to reduce the problem of mortality.
Thank you, Dr. Nze.
Yeah.
Thank you.
Sorry, there's if you allow waridha yako.
Okay, just one minute. Yes.
Less than a minute, I'll respond to the question of tracking registers. I just want to say that we have developed the UCS system, that is Universal Community System for Tracking, but this it's not complete. We are still developing it, and we hope to roll it out to the whole country. So in some areas it is not available, but we are doing that. We are hoping that we are going to track these women from the community level, taking into consideration that we have started the community health workers program in this country. Asante sana.
Thank you. Let's go to Dr. Arias. I think you have one question from the audience. Just in 1 minute, could you tell us about...
Thank you very much. The question about tracking the utilization of the training that has been received with providers. There are many modalities of on-job training, and this has been normal that you train people, but when they go back to their working place, they don't use that training. So the modality that we are recommending and that we are doing with the Minister of Health, most of the time with support of UNFPA, we are focusing on low dose, high frequency. That you call people, pull people, you train them on specific skills, and then you follow up them. You can follow up them, you can do on-job, on-site mentorship, or supportive supervision, or both, to ensure that the things that have been trained, people are implementing them. So you don't train people and leave them. Train them on a specific skill, follow them through mentorship or supportive supervision. In that way, in one way or another, people will utilize the training that they have received. Thank you.
Thank you, Dr. Arias. I hope that answered the question. Ms. Rahma, you also had one question. Please, could you respond in 1 minute?
Thank you. I think I had two. One is on feedback mechanism from drivers, and another one on the interregional calls. So with the feedback mechanism, yes, I think we have a gap there, because the only opportunity that the driver has with the leader is during when they renew their contract annually. Most of the time they will communicate with the dispatchers and get their feedback from the dispatchers in case they have anything. But I know there are a lot of effort that is done with the government. For instance, now they are piloting what they call driver mobile app. We know it has its limitation because it will only be accessed by the driver who has a smartphone and not the one that has Kiswanswadu. So we have a gap there, but there is some effort to just make sure that there is that part of tracking the drivers, but again, also getting the feedback from the driver. And hopefully, when it is actually rolled out across the country, we can see how the improvement will go from there. So yes, I agree that we have a gap there, and I will definitely say there has a lot of improvement that has been done so far by the government since the kickoff that we had for the first regions to now the national rollout. There's so much of improvement within the MMR system that the government has pioneered. In terms of the interregional calls, yes, that's one of the gaps we have around our communication in the country and the towers that we have. But there has been quite really an improvement as well with Ministry of Information and Technology to just make sure that the calls that are coming are tracked and they improve, that they go to the specific region. But now the MMS system as well has now received inter-regional calls. So when you get a call, when your call is received with a different region, they will definitely call the call center to call you back on what challenge did you face, or what kind of referral that you needed. So there is an improvement there. And if you can allow me, I just want to insist on the data and usage of data. And I think that's the area that most of the stakeholders we can use and leverage on. I can use an example of mMama, where you have massive, massive data. What you're saying, Dr. Daddy, what Dr. Yvonne is also saying, I think when we go back to the data and see where are the bottlenecks are and where we can concentrate our effort and resources, then I think we don't need to do everything everywhere. We can focus where the needs is. Thank you.
Thank you very much, Ms. Rahma. I hope also that answers the questions from the audience. Mr. Jumanne, we also had questions.
Yeah, I think mine was exposure for university students. Very quick, 2016 we did a project with HIDIF through DFID financing to test a concept where you put a group of doctors in a room and then tell them to come up with a solution for health issues. And we reached out to 13 universities, medical and allied sciences universities in Tanzania. And we had over 60 teams of young students working on innovation. 10 years later, these are the founders of Dawa Mkononi, some of the folks at Afya Intelligence, some of the folks at Mkanda Salama. So I think the best way to get medical and allied students involved in the innovation ecosystem is actually to get them in the innovation ecosystem. And how do you do that? Is through Innovation Challenge, on-campus innovation hubs. If you can establish co-working spaces on the campus to promote innovation, that's the best approach to do it. With a MOO accelerator, most of the young people who are applying to be part of the program, they are medical doctors themselves, and the way we recruit them is through university programs. You establish either an innovation challenge or a hackathon, something like that, just to change their mindset and also to get them to develop interest to actually think beyond just being doctors, but also solution creators specifically for the health sector. So that's the best way to get you guys exposed and give you opportunities. So next time you hear there's an innovation challenge or there's a hackathon or accelerator that is looking for health and innovation solutions, just please apply and be part of it. I think the next cohort of a MOO accelerator will be announced. Just find a way to apply and be part of it. But also I know MUHAS, for example, they have an innovation hub on campus. As a university, I don't know, Kairuki and the rest, you can actually try to have your own on-campus innovation hub. There's a lot of talent and innovation coming from Tanzania in the health sector. Yeah.
Thank you, Mr. Jumanne. Please give us 3 more minutes as we wrap up this panel. Dr. Beatrice, is there anything that you want to conclude on during all the discussions that we have heard so far?
Yeah, thank you so much. And following the discussion, I would like to humbly request the government to have second, if not the 5th eye, to invest in midwifery. Because most of the midwives are the frontline workers when it comes to supporting mothers, supporting newborns, supporting our children under 5, and supporting adolescents. So I believe if the government can work on deploying midwives, and even ensuring the welfare of midwives who are already working in hard-to-reach areas, in the rural areas, I believe we are going to really reach the target that we have of ensuring by 2030, we reduce the maternal mortality ratio to 70 maternal mortalities per 100,000 live births. So, and I would also like to request other stakeholders also to invest in midwifery, and as an association, we are eager to work with whoever is ready to support us in ensuring that we capacitate midwives in the country, and for Tanzania to become as a center of excellence in providing better maternal and newborn health services. Thank you.
Thank you very much, Dr. Beatrice, and thanks again to all the panelists. Can we give a round of applause to our panelists for responding to our question very clearly? So the takeaways from this discussion would be, let's leverage data to improve the quality of the services that we provide, but also innovation has been discussed as a way to go, so let's also focus on that more. And each and every one here of us has a role to play. So let's please strengthen our partnerships in improving the quality and services to the mothers and our newborns. And there was a call from Madam President as a bonus, yeah, that she calls on the investment of midwives as to give the quality care to the mothers and newborns. Thank you very much. Could you also stay for 1 minute? I know I've been standing between your breakfast and this time, so could you please spare 1 minute to have a group photo with the panelists? Volunteers, could you help us with the tables and the chairs? And I welcome all the audience on the stage for a group picture. Karibuni. I'm told there is an award. Mr. Mzee, would you give us an honor of giving the award to the UNFPA? Yeah. Can we have the award, please? Miss Marisa, let me call you up on stage for the award. It's an appreciation award.
And Mark is informed and he proposed that we talk.
Zote mbili, Naweka hivi?
Yes. Zote kwa pamoja. This is an award from Tanzania Health Summit to the UNFPA for being a strategic partner for the forum. Thank you all. For those who are still here, you are welcome on stage for a group photo with the panelists. Tukae chini alafu wao watasimama nyuma. Atusogeze mbele kidogo. Volunteers, mtusaidie kusogeza viti mbele. Subiri basi tutarudisha. Okay. Tumesha. Sawa. Okay. Welcome on stage for a picture. Karibu, Melissa. Yeah, the panelist and you. Melissa at the middle. Ziweke hapo tutachukua.
The government guys.
Please welcome for the photo. Karibuni on stage for the photo. All the audience, karibuni please. Thank you very much. Thank you.